Hi, this is Jeff Lyhall from Anesthesia and Critical Care. The intent of this talk is to fill you in on some details about patients who require intubation. I think all too often patients are regarded as kind of the province of anesthesiologists when they're intubated, and people kind of stand back and let them do their thing, and then bad surprises sometimes ensue following the intubation. It's much more preferable to have an idea of what kind of problems will arise, anticipate those, and try to ward them off with a little bit of analysis and maybe some better monitoring prior to intubation. So I'll take, for example, a patient who's 65. He's got COVID-related pneumonia. He's doing okay at home for a while, and then finally presented to the hospital with some pretty significant respiratory insufficiency. He was anxious, obviously tachypnic, and his saturations were only 89% on room air. Otherwise, pretty well compensated, but definitely seemed time to admit him and have him more closely observed. So for the last day or so, nasal cannula oxygen seemed adequate to maintain saturations in the low 90s and was a pretty stable regimen. Although in the last 36 hours, the patient became progressively worse. He's had a poor appetite, lethargic, not really interacting with staff, and more recently, he's had a pretty well documented decrease in respiratory rate, approaching 30s. Some self-proning was attempted just to try to get him to roll over and position himself and try to ventilate the dorsal parts of his lung, and those only presented transient improvements in his oxygenation status. So now he's in significant distress and much less engaged overall. So in addition to his comorbidities, and this is kind of generic for any patient, we don't know if they have heart failure, hypertension, diabetes, whatever. So he's clearly hypoxemic. He's got bronchial breath sounds in his bases, and presumed to have a pneumonia. His chest X-ray is somewhat unremarkable, but his CT does show some peripheral ground glass opacities, and currently he's normocarbic. So he has some depressed mentation even though his stats are okay, and his blood pressure is actually a little bit higher than his norm of about 120s over 70s, as shown there. So what else could be going on with this patient? And so, again, you think about the respiratory status, take care of that by putting him on the ventilator and try to optimize his ventilatory status by dialing in PEEP and higher fractions of oxygen. That's all fine, but the other things that are really plaguing this patient are frank hypovolemia, also by his blood pressure. He's actually in extremis, and this is a sign that basically his impending sense of doom is what's keeping him alive. So even though he might have some crummy little 24-gauge IV going, he's actually on a pretty significant epinephrine drip. And you definitely need to recognize that, because as soon as he's given any medicines to make him unconscious for intubation, that's going to get shut off and he's going to be crashing like crazy. Also, there are pauses in ventilation during intubation, and this guy's probably got a pretty reasonably high minute ventilation, probably 15 plus liters per minute. And so his oxygenation is definitely going to get worse during intubation, and his CO2, which is normal, could very well rise. Sometimes patients who have high CO2 to begin with have some cardiac instability. Often they have arrhythmias, PVCs, they could be in an SVT or AFib, and you never know how all this is being handled by the right ventricle. Overall too, despite the fact that this patient has what you consider a normal or adequate blood pressure, probably his overall oxygen delivery to his periphery is pretty low, and that might be what's causing some of the problems with his mental function, although probably just this general state of fright is just getting him to focus strictly on keeping himself alive. But in these situations, a lot of end organs are at risk as soon as the patient gets intubated, and that's going on already. So what will intubation do to this patient? First off, it's going to completely invert all of his ventilatory dynamics. So currently, the patient is drawing air in with diaphragm contraction, and that's actually causing air entry into the base and dorsal parts of the lung, where actually the blood flow is the greatest. So despite crummy saturations, he probably has pretty good VQ matching as far as looking at perfusion of vessels. Now you're going to completely change that. Now you're going to be pushing air in. And so the most compliant parts of his lung, which are the apices that probably aren't getting that much blood flow, are going to get all the ventilation. And you're actually creating some risk for overstretching those regions and causing some ventilator-associated lung injuries. So that's going to completely change. A lot of times the positive pressure will actually cause compression of the heart, and that will impair venous return to the thorax. This is a patient who's already hypovolemic and probably reasonably volume responsive, and now you're going to take away volume during respiration rather than drawing blood back into the thorax during respiration. You're kind of excluding it with the positive pressure. As mentioned before, all of his endogenous catecholamines, which are keeping him alive, are just going to get shut off instantly. Even if the anesthesiologist uses, supposedly cardiostable medicines like etomidate or ketamine for induction, those are still just going to completely shut off the patient's consciousness, and their epinephrine is going to get shut off as well. So also, skeletal muscles are relaxed for intubation, understandably so, and skeletal muscle contraction actually excludes some volume from the venous parts of the muscles. And as soon as you relax those muscles, your capacitance is going to increase, and you're going to have a huge increase in unstressed volume, again exacerbating hypovolemia, which you have clinically because the guy has insensible losses, second, no PO intake, third, decreased venous return, and now you're going to park even more in the periphery. If succinylcholine is used to paralyze the patient, sometimes potassium fluxes can be very high, if not fatal. That's particularly the case for patients with spinal cord injuries, people who've been in bed 2+ to 3 weeks, patients who've had strokes and just really have not had much neuromuscular transmission overall. And so those are the patients that will have upregulation of their junctional acetylcholine receptors, which will then, when depolarized by succinylcholine, trigger massive potassium release. Hopefully the anesthesiologist will take in enough of the patient's history to avoid that, but anticipate that the potassium level might be relevant to the anesthesiologist. So if you know that, definitely write it down or just get a good value that you can quote the anesthesiologist. And so with all this happening, it's, believe it or not, very, very common for patients in extremis who get intubated to actually have cardiac arrests and codes very quickly thereafter. And how do we react to that? Well, we're doing chest compressions in a lot of cases, and then the patients are just getting massive doses of vasopressors, like those milligram sticks of epinephrine. And then, just from our own anxiety, we're just sitting there just cranking away fluids like crazy, and sometimes in amounts that might be excessive to what the patient really needs or can tolerate. So your goal is to prevent all this. And so you can't prevent someone from being an extremist, but you can anticipate some of the issues that are named above. So for example, you can take a look at the heart, see what it looks like. Is it a pretty dynamic, hyperdynamic heart? Does the RV look like it's keeping up with life? Just start cataloging some of these heart problems in your mind to figure out how you're going to take care of the patient if they become hypotensive following intubation. Definitely get an art line in early. When they've got a blood pressure, it's way easier to get in than when you're crashing and pushing vasopressor boluses and their arteries are spasming. All these patients that are getting intubated, there's totally an art line in their future. And in fact, prior to intubation, you might be doing various interventions as well, and you would be interested in knowing what the CO2 and the oxygen is and having those values. But also just due to the fact that the patient will lose a lot of blood pressure during intubation, having that art line for that event so you can see it happening really early on and kind of steer your way out of it, rather than having a blood pressure cuff go Q 1 minute and only getting your answer 2 minutes later when the first blood pressure comes back at 0 and then it's cycling again. So, looking at your echo, if the patient looks like their papillary muscles are just crashing against one another, this is somebody that can benefit from gentle hydration. I know that's kind of heretical in lung injury. We try to run these guys as dry as possible, but if they're going to crash and code because they're so dry, you absolutely have to rehydrate them. That's just going to help their oxygen delivery anyhow. So the other thing that you might want to work with your anesthesiologist with is there's some patients that actually do better with spontaneous ventilation, meaning their diaphragms are contracting and they're getting better VQ matching. So if talk to your anesthesiologist about this, because they can use some agents like succinyl choline, which only last 4 or 5 minutes, rather than rocuronium, which is probably 45 minutes to an hour for every intubation dose. And so they might not have that big crashing blood pressure because of positive pressure ventilation if you can get them breathing spontaneously pretty quickly thereafter. It requires pretty good amount of finesse and careful selection of doses of sedatives, so you just can't slam on a bunch of fentanyl and Versed and propofol and expect them to breathe and cooperate with this kind of plan. But if you can accomplish this, that could make for a much more stable course. I've crossed fiber optic here, but often if you have someone who's just absolutely an extremist with respiratory failure, sometimes fiber optic intubation is a great way to go, because you're not slamming paralytics in, you're not slamming a bunch of induction agents, you're not turning off their endogenous catechol drive, you're letting them breathe spontaneously, and you're just giving them baby doses of narcotics so they can tolerate the tube, and so it can be kind of a humane experience for them. The other thing is, with an ART line in place, as you start to give, you can start giving like baby test doses of some of your induction agents and really see, is the blood pressure just going to fall apart instantaneously, and you can, with a little bit of knowledge along those lines and seeing what's happening to the blood pressure in real time, you can start titrating in preemptive doses of vasopressors to prevent big crashes in blood pressure. So have those ready. All this can happen before the intubation crew arrives. You can completely anticipate a lot of these issues just by your own knowledge of the patient and some of these stereotypic responses to intubation. And finally, there are some patients who you encounter who have CO2 that's rising prior to intubation, and perhaps maybe their problems mainly hypercarbic respiratory failure from hypoventilation. And a lot of these patients can have some pretty significant cardiac instability. And so if it's undesirable to mask ventilate these patients due to generation of aerosols, if you can slip in an LMA and get a good fit, you can actually ventilate these patients for a number of minutes while you're waiting for your paralytics to become fully active, and you've got a good seal. You're not spewing a bunch of virus and aerosols into the atmosphere. You could put a filter trap on your ventilatory circuit and use an ambu bag through an LMA and really kind of normalize some of their blood gases before you intubate them, and that could actually prevent a lot of arrhythmias that might occur when you actually do intubate them. So those are the main points I wanted to cover. Really, intubation is a team sport, and your involvement with the patient, your knowledge of what is going on with their heart, with their vasculature, with their overall behavioral disposition, sense of fright, etc., and kind of knowledge of what might be underneath the hood, as well as anticipating some of the stereotypic changes that do happen with intubation and positive pressure ventilation. This can actually help the patient have a much more smoother course overall and prevent a lot of big disasters and other big shocks to the system from happening.